Thank you very much, everybody, for coming today. Welcome to the debt certification update today. We've got some amazing speakers today, and thank you very much to them for sparing the time this evening to share their wisdom with us and sort of go through the debt certification, not only the sort of traditional and sort of things that would be covered, but also an update in the view of the recent update in particular that's been covered as well today. So the session is being recorded for our sort of view later on Team Net, as well as our NATH YouTube channel as well. So, feel free to pass it on to your colleagues who are not able to come this evening, and they could always watch the recording as well further. So I'm going to just give a little background about me. I'm Saira. I'm one of the, I'm a GP, but portfolio GP by background, and I'm GP associate for Nottinghamshire Alliance Training Hub, who brought you the training today. We do a number of CPD events, as well as the sort of support, the multi-professional support unit as well. So I have got today with me Dr. Nina Lewis and Dr. John Murray. So Dr. Nina is a consultant physician at Nottingham City Hospital. She is a community medical examiner lead for Nottingham City and South Nottinghamshire. And we've got Dr. John here, who's a medical examiner, medical referee, and a former GP as well. So thank you very much for coming. I'm just going to go through quickly the Grow-Nots primary care app. You can download that on your mobile phone, both Apple app and Google Play Store. The Grow-Nots PC app is all one word. So Grow-Nots PC is one word. Just remember that. But otherwise, a single point of access app that we are trying to sort of, it's free for all primary and community care workers in Nottingham and Nottinghamshire ICB. But also, you can put a filter on there and it will have an easier access to your CPD, etc. So I will stop sharing that now, and I would pass it on to my amazing speakers today, who can then take over. Thank you very much, Nina and John.
Thank you very much, everybody. I think I'm introducing the first bit, and then Nina will do some stuff, and we'll kind of bounce backwards and forwards, which I hope is okay for everybody. First thing I want to say is that there have been, as I'm sure you've noticed, an awful lot of changes over the past few months. In Nottingham City in particular, we have been extremely well placed to absorb those changes. We hope you haven't noticed a great deal of difference, because, to be honest, the GP community in Nottingham has really been excellent at embracing the medical examiner service well before it was mandatory. If you just move on to the first slide.
Could I just make sure that the PowerPoint is up and the slides are moving through?
Yep. Great. Yes, thanks, Nina, it is.
So move on to the next slide, please. So this is what we're going to try and cover today. We're going to cover the process of how to verify a death, who can write a death certificate, how to write a death certificate. Nina's got a big bit about referral to the coroner and which cases and how to do it. Then I want to talk a little bit about how you interact with the ME service, and then just a little bit about special circumstances. I think the best way of probably making this as interactive as we can is each time we sort of swap speakers, it might be worth, if anybody wants to raise their hand and ask anything, then we'll do our best to answer them at that time. And then we'll hopefully have plenty of time at the end if should anybody want to ask any questions.
That sounds great.
So we've got the next slide. How do we define death?
Hello, darling.
You can all read. So I don't think I need to read that out to you. Can we have the next slide, please?
Thanks, John, and sincere thanks to Saira for inviting us to meet with you this evening. Thank you for a very kind introduction. I'm Nina Lewis, who's the head of the Suspected Cancer of Unknown Primary Pathway, and then my other role is also as the Community Medical Examiner Lead. There is a guidance and there is a handout. The handout is the guidelines that have been recently published and ratified by the Senior Coroner on Friday. Saira will be emailing each of you this guideline as a handout. Much of the content of the talk we'll be covering this evening will all be contained within these partner-wide community death guidelines. The guidelines will also be emailed out to all GP surgeries within Nottinghamshire, with hopefully a standardised approach towards the death administration, if I can put it as bluntly as that, across the patch. Such guidelines I've revised with the medical coroner, Dr. Didcock. The reason for updating was because of statutory changes in death certification reforms, which Uncle John and I will review this evening, as well as EMAS implementing NHS Pathways, which again is contained in the guidance as well as in our talk this evening, as well as of relevance to those GP colleagues who perhaps work in the out of hours GP provider services such as NEMS regarding the verification of death by registered nurses. Certainly I get to hear about the ping pong of who can verify a death. Oh, it's a NEMS colleague. Oh no, EMAS do it. No, EMAS say that police must do it. So I'm hopeful that both the guidelines will help dictate who is responsible for verifying death, as well as reviewing a hands-on approach in the talk this evening. So with respect to defining death, I think it's important to point out of what is an expected death. Within the guidance, this section is lifted purposely and shared on this slide. No doubt our GP colleagues are very au fait with the definition of an expected death. It's a death which is anticipated, predicted, and there's also documentary evidence that our GP colleagues will share in their primary care records, whether System 1 or EMAS. EMAS and Manic Aurora have worked very closely with the palliative end-of-life care information standard to try and encourage also documentation in the form of SNOMED codes that person is on an advanced end-of-life care plan, and the purpose of that is to allow EMAS to quickly search on their NHS Connect records that they have on their iPad when they travel to a job. Is this person an expected death or an expected decline when they're invited to go and assist? And I think there's a real push, as well as updating the gold standards framework to amber status, and on the EPACS register to an amber or red status, to also include these codes for ease of access and searching. With respect to who can diagnose death in England, in the UK, any doctor who holds active registration with the General Medical Council can diagnose death, but from observation of who is diagnosing death in Nottinghamshire, less than 2% of death verification is done by a GP. 3/4 of deaths are expected, and it's our tireless work of our district nurses, our community nurses, who do the heavy lifting when it comes to death verification. The remainder of deaths are verified by EMAS colleagues, police colleagues in an unexpected death. So with respect to verification of death, there is a recently issued guidance from the Royal College of Nursing, which applies to so-called registered nurses who are assessed as competent, and they're working within their care setting to verify the death of an adult as defined by a person who is aged over 18 years. And the guidance stipulates that the following conditions must apply with respect to allowing a registered nurse to diagnose death in the community. Such a death is expected. We've got the definition of what an expected death is, and such a death is not to be accompanied by any suspicious circumstances. Another condition is that there's been some form of conversation with advanced care planning, such as the respect form, the do not attempt cardiopulmonary resuscitation, and this is recorded formally in that person's clinical notes. However, if there is obvious evidence that the person is deceased, but without such a DNR CPR conversation documented, or without a valid respect form, but there is really very much evidence of irreversible death, such as the presence of rigor mortis, a verification of death can still be done by a registered nurse. So when you get calls in the daytime of oh, it needs to be EMAS, it needs to be the police to go and verify the death. The first thought process is this an expected death? Are they got all the boxes ticked on their records of the advanced end of life care planning? If so, it's an expected death. And
could you see me?
Sorry, John, what was that?
No, I don't think it was John. Can you please all keep the mute button? Yes, so you can carry on. Sorry, I think it's a background noise.
So for a nurse linked to the practice can go out and verify that person's death, even if death had been present for some time, such as the presence of mummification, let alone rigor mortis. And the same would apply out of hours of NEMS can delegate a registered nurse to go and verify the death, rather than the ping pong that occurs between EMAS and police. Likewise, if the death occurs in a private residence or a hospice, residential home, nursing home or hospital, then equally death verification can take place by a registered nurse. And it also includes nurses being able to diagnose death where the patient dies under the Mental Health Act, including deprivation of liberty safeguards. And of important note is that there's the loss of the 28-day rule, in that a registered nurse can verify the death even if a doctor has not seen the patient within the preceding 28 days. There are a number of statements issued in this guidance where specifically a registered nurse can't verify an expected death which is believed to have occurred in suspicious circumstances, and it remains the right and responsibility of the verifying registered nurse and or the competent person, such as the care assistant in the nursing home, to request the attendance of the responsible doctor or the police if at all they feel there's suspicious or unusual circumstances. There are other clinicians in the community that are able to diagnose death, which includes ambulance clinicians, but with the drive to reduce ambulance turnaround times, our local ambulance services have implemented NHS Pathways, and they've made it very clear that EMAS will no longer be dispatching EMAS clinicians to attend a job to verify an expected death. That will be the duty of registered nurses within the guidance issued by the Royal College of Nursing. And if it is an unexpected death, but it is very clear that death has been established not only for several hours, but several days or even several weeks, such as established putrefaction or mummification, then EMAS will again decline dispatching clinicians out on the job to verify death. And their statement is that EMAS is to be reserved for patients who EMAS can provide life-saving interventions for. It's not a cut-off of we're not here to help. The EMAS team leader will provide medical advice through contact, but this will be very much governed through NHS Pathways. In the community guidance are quite didactic appendixes according to who you are and of relevance to the GP surgery. It again splits who is able to diagnose death according to if it's an expected death and if the death is unexpected. Now, of importance of what is an unexpected death, it's the converse of a expected death, in that there's no documentary evidence in primary care records that the person was nearing their end of life, no valid respect form, no valid completed DNA CPR. With all unexpected deaths, the police must be informed and the police must attend the scene of death. And it's the police to liaise with the coroner out of hours if required. EMAS may be contacted in an unexpected death, but that is usually that they have come and attempted resuscitation. They will do what life-saving interventions that they can offer, but they are required to leave the scene as soon as any EMAS life-saving interventions have been offered and delivered, leaving the police at the scene. So I often get complaints, phone calls in the middle of the night with this ping pong between where's the police, is it EMAS, is it NEMS, is it the GP, is it the district nurse? But hopefully this didactic guidance will help guide. Is it an expected versus unexpected death? The role of EMAS and the role of police to attend all unexpected deaths, and it's the police to lead the administration of an unexpected death. Just of note, with respect to expected deaths, EMAS, as you know, have NHS Connect on their iPad containing the primary care records of the patient. That means that EMAS should not be contacting GP surgeries to say, oh, can you give me a handover? Can you give me extra information? No, it is all contained within NHS Connect, held on the EMAS iPad. The only case where that falls down is where the patient doesn't have a registered GP, and the advice that we give is that EMAS should notify the hospital that they would normally have used to take such a patient if they were alive as their linked hospital in a so-called unexpected death by virtue of not having a registered GP with no access to primary care records. And I pass back to John, if I may.
Yes, of course. Thank you, Nina. So were there anyone raising their hands at this moment that we need to answer any questions?
I haven't got anybody, but please could you ask any questions at this stage if you have for Nina? And also please do use the chat box at any time. We will be monitoring it and reading it and answering, hopefully.
Right. So next thing I'm going to talk about is how to verify death. This is something we've all been doing for an awfully long time. I don't recall ever being actually taught formally how to do this. In theory, it is a 5-minute check for the absence of all these things. Though, as Nina has mentioned, often in the cases of established death, it's pretty straightforward. Next slide, please. So this is one of the big changes that's taken place from September about the details of who can write a medical certificate. So the first thing is only medical practitioners can write death certificates. There is constant chatter about whether or not nurses will be able to do it. There are no plans for this at the moment. There used to be a rule that you did have to see them in the 28 days before death, or you would need to see them after death. That's now disappeared. You don't have to see them face to face, but you must have attended the deceased at some stage during their life. What does attended mean? We don't really know. It's not clearly defined, but we as medical examiners are generally interpreting this as you have made a meaningful decision about the patient's care. So it's more than signing a repeat prescription, but it could well be having a conversation, for instance, with the district nurse about a syringe driver, or having a conversation over the telephone with the patient after they were diagnosed with cancer or something along those lines. There will be grey areas, and as MEs, we're happy to discuss that with you. The next thing is you must know the cause of death, but this isn't absolute certainty. This is on the balance of probabilities. So if you 51% think that a patient has died of a certain condition, then that is acceptable. The final thing is there's no longer any necessity to view the body after death. There is one reason I can think of, which I will come onto a little bit later, but as a general rule, there will be no need for those trips to the funeral directors anymore. Can I have the next slide, please? We, as medical examiners, sit in an office together and we have long conversations about how to write a death certificate. And what I'm going to say now is how we make those decisions. And this is what we would hope would be the thought process that you guys go through when you're suggesting a cause of death. So 1A, 1B, 1C, 1D, which is new, and 2, you can read all of this stuff, but the idea is that 1B leads to 1A, 1C leads to 1B, 1D leads to 1C. Next slide, please. I'll give you some examples which I hope will make this a bit clearer. Can I have the next slide, please? Right, lovely. So the sort of classic example of what a wonderful MCCD should look like. So 1A, myocardial infarction, which was caused by ischemic heart disease, which in turn was caused by hypertension and type 2 diabetes. Next slide, please. So here's some things that we talk about. We generally suggest causes of death rather than a mode of death. So generally, myocardial infarction is considerably better than cardiac arrest. There are occasions when it is appropriate to write cardiac arrest down. We do sometimes suggest this, and this leads me really to just a very brief discussion about what is the death certificate for. And there are two reasons, in my opinion, why we write death certificates. One is to give information to the next of kin. So the next of kin look at these and they read these. And sometimes it is appropriate to put that cardiac arrest in because it will give a sort of cogent explanation to the next of kin. So the example I can think of was one that one of my colleagues wrote about a month ago. This was a patient with a congenital heart abnormality who collapsed and died. And we had a discussion about this, and we felt that writing cardiac arrest 1A and 1B, the details of the congenital heart abnormality, actually gave a better explanation for the next of kin. The other reason we write death certificates is for information for the Office of National Statistics. And that will become a little bit more relevant later on. Can I have the next slide, please? So here's an example. This was the classic example that used to be given in the information about how to write a death certificate. We wouldn't necessarily agree with that way of writing this particular death certificate anymore. And if I can have the next slide, we would probably write this one as, so missing out the bit about the peritoneal hemorrhage, which is a mode of death rather than a cause of death, keeps it simpler, metastatic colon adenocarcinoma. So you're giving the correct information. Where's the site of the cancer? What type of cancer is it? That sort of information is quite useful for the Office of National Statistics. Next slide, please. What sort of information needs to go in part 2? Well, this is an example that I usually come up with. So we've got cardiac failure caused by ischemic heart disease. That's fairly straightforward. Why have we bothered putting the mixed dementia in part 2? Because this may well have contributed to the treatment decision. So you've got a patient, for example, who you've got treatment options of really pushing treatment for the cardiac failure, but for example, excessive diuretics could cause problems with continence, could cause much more difficulty in the management, could cause distress for the patient. So the mixed dementia may well have had quite a significant role in making treatment decisions. Next slide, please. Sometimes it's difficult to decide which condition actually led to the death. By and large, we like to put one in a line, but sometimes you can't actually decide. So it's perfectly okay to put heart failure and lower respiratory tract infection, ischemic heart disease and chronic obstructive pulmonary disease, if you think that they have both contributed equally to the death. Next slide, please. Next thing, it is perfectly okay to just have a single cause of death on a medical certificate. Sometimes we see this written down, so mixed dementia, and then someone's listed all sorts of things in part 2. That's often not necessary when they died of the dementia. Next slide. This is another little bone of contention. Frailty or old age, they are acceptable diagnoses, but shouldn't really be used willy-nilly. So I did notice that Her Majesty the Queen was put down as dying of old age. Actually, given that she was walking around and meeting Liz Truss, I think it was the day before or 2 days before she died, I'm not entirely sure that that would pass muster with the Nottingham medical examiners, because generally there should be a clear history of progressive decline before you start putting the frailty or old age down there. But again, where you've got a natural death and you can't find another cause in a patient who is elderly, we don't want it down for 40-year-olds, then that's okay to write down. Next one. So this is an actual example of a suggested cause of death. What's wrong with it? Next slide, fairly obvious. If I can have the next slide, please. The peripheral vascular disease doesn't cause a myocardial infarction. So we would normally swap hypertension and type 2 diabetes, put that in 1B and the peripheral vascular disease in 2. We've already got the next slide, which is great. What's wrong with this one? Remember that the death certificates are going to be read by the next of kin. It is useful to avoid abbreviations. We really don't like CVA even written out in full, accident. A lot of next of kin really don't know how to interpret that one. Next slide, please. Right, so falls. We in the medical examiner's office often discuss falls. If the fall led directly to the death, then that probably needs to be referred to the coroner. Dr. Lewis will discuss this, I think, in a lot more detail than I'm going to. But falls are often a symptom that a patient is becoming frail or declining. A fall is often a symptom of a urinary tract infection. A fall can be a symptom of a stroke. If you have a stroke and you're standing up, you'll probably fall over. Did you die of the fall? No, you died of the stroke. The next one we discuss a lot is surgical procedures. Where a patient has surgery to try and save their life, we generally consider the cause of death was the condition rather than the surgery. So the obvious example is a ruptured AAA. If you rupture a AAA, you are going to die unless someone attempts to save you. The success rate of the surgery is in many cases not that high, but from a personal point of view, if my aortic aneurysm ruptures, I'd like someone to have a go. And I don't want to start discouraging people from trying to save my life by insisting that every surgical procedure is reported to the coroner. Next slide, please. I'm just going to quickly run through the new death certificate. You've hopefully all seen these, but 1D is a new line that's in there. I am going to hold our collective hands up. Our referral form doesn't yet reflect 1D in there, but if you think it needs a 1D, write it in somewhere and we will take account of that. Next slide, please. There's a pregnancy box. For the majority of patients, this isn't relevant, but still got to be answered. Next slide, please. There's a box about industrial diseases. One of the things I'm going to point out, our medical examiners officers speak to all the next of kin after the medical examiner has done a scrutiny. They are really, really good at finding out about industrial diseases. I am pretty sure that their information is considerably better than the information on our GP computer systems. And so it's not infrequent, I suspect, that we will get back to you and say, look, I know this seems like a straightforward death, but we've found something in their past occupation. They worked at the power station 30 years ago that you would know nothing about that necessitates referral to the coroner. Next slide, please. The ethnicity question, again, pretty straightforward and pretty self-explanatory. Next slide, please. Implantable devices. This is the one that caused lots of fuss. First of all, it should say hazardous implantable medical devices. The powers that be have acknowledged they made a mistake. They're not going to change it because they printed an awful lot of death certificate books. I imagine at some stage in the future it will be changed. So it is the same interpretation as we used to use. I have to say that it remains the person who fills in the death certificate's responsibility to answer this question. And you'll notice there isn't a don't know box on there. The answer is either yes or no. If you really can't find out, then please contact the ME office, because sometimes we can find X-rays and CTs and we can answer the question for you. And we're very happy to try and help. If you're not sure about it, again, just ask us, because we tend to know what needs removing and what doesn't need removing. And I'm going to give you a list of things later on. And in fact, we'll move on to that now. So, sorry, can you move back to the previous slide? Sorry, I've been a bit quick. So basically, the hazardous implantable devices are anything with a battery. Some radioactive implants, and the commonest situation is prostate cancer. And then there's a thing called fixions, which everybody gets very excited about. I'm delighted to say I don't think one has been put in Nottingham this century. For those of you who don't know, fixions were a form of hip replacement where they were fitted in place by putting compressed air into a metal tube that goes down the femur. Think of something a little bit equivalent to a soda siphon bulb. You heat those up, they really do go bang. There's an argument about how much damage pacemakers can do in a cremator, but fixions really do cause damage. But it's incredibly unlikely you'll ever come across one. In 25 years working at the Crem, I've never come across one. Next slide, please. Final box on the new death certificate is the bit that we have to sign. It seems to be working quite well that once we've agreed a cause of death, you send the death certificate to us and we sign it, and then we pass it on to the registrar. I hope it's working okay from your point of view. And I'm going to pass back to Dr. Lewis now.
Great, thanks, John. So I'm going to very briefly cover which deaths require notification to the coroner. The medical examiner's service setup is set up so that we look to our GP colleagues to share the relevant primary care records, which is typically 6 months predating that person's death, and to look to what I call our how spoilt we are by having world-class GP colleagues in Nottinghamshire to share their steer about what they think has happened. So we don't expect of this person's death needs to be notified to the coroner for XYZ reasons, but it's just so helpful for the heads up of something's not quite right here, and that just gives us that extra leg up to look through that person's journey leading up to the death, so we can make that call whether or not it was an expected death from natural disease progression, or whether the death requires notification to the coroner. Sorry, would you mind going on mute? That's brilliant. So the law states that certain types of death must be reported, by a registered medical practitioner to the coroner. And you may have heard, perhaps through personal attendance at coroner's court, of whether the death has more than minimally, negligibly, or trivially been caused or has contributed to the death. And I'm going to run through what certain circumstances deaths need reporting to the coroner. Occupation is one common call need for notification to the coroner. So diseases in the course of employment, such as a former rather than a current coal miner. I don't know if there are any local coal mines still open, who died of coal mine pneumoconiosis, or perhaps a construction worker who's died of asbestos-related lung disease, such as asbestosis or mesothelioma, and then the plumbers, the radiation engineers who are exposed to asbestos lag pipes that we always think of and review imaging on their hospital records to see if there's any evidence of such asbestos-related lung disease. Was the death due to poisoning by an otherwise benign substance? This applies to deaths due to deliberate or accidental intake of poison. In regard to alcohol-related deaths, only deaths due to acute poisoning should be notified to the coroner, but not deaths due to natural chronic disease, such as alcohol-induced cirrhosis or alcohol-induced cerebellar atrophy. If the death was due to exposure to or contact with a toxic substance, for example, carbon monoxide poisoning, then such a death should be notified to the coroner. If the death was due to the use of medicinal product, the use of a controlled drug, or a psychoactive substance, then the death is also required to be notified to the coroner. Such a medicine may be well prescribed and for an appropriate indication, but is being causal or contributory to their death. For example, bleomycin in a hospital setting is standard first-line treatment for germ cell tumours, given in an act to try and help preserve life from dreadful cancer. But we know bleomycin can be associated with pulmonary fibrosis. So if there was development of such a drug-induced pulmonary fibrosis that was causal or contributory to the death, then that death would be required notification to the coroner. Even if it was an idiosyncratic reaction, it requires notification. Paracetamol, deliberate ingestion, would also fall in this category. Principally in the hospital setting, but previous trauma in a person's life, of particular relevance in a community setting, of a so-called unnatural death, where death as a result of violence, trauma or injuries inflicted by someone else or by themselves, or sustained in an accident such as a fall or a road traffic collision, whether historical or current, is considered an unnatural death, and as such requires notification to the coroner. If the death was due to a procedure, rather than the death being caused by the condition for which the procedure was undertaken, then that death requires notification to the coroner. I was involved in a very harrowing inquest where death was caused by ERCP endoscopy procedures, where patients died of the endoscopy instrumentation rather than the actual death caused by biliary pathology. The particular case I was involved in was when a patient died of esophageal perforation caused by the ERCP instrumentation rather than the cholangitis for which they've been referred for such instrumentation. Conversely, as John has commented upon about life-saving interventions of the spontaneous rupture of an abdominal aortic aneurysm, and equally of emergency angiography with preceding to angioplasty, should there be rupture of the coronary artery due to diseased plaque rather than poor technique at instrumentation, then it's a disease-related process rather than a procedure direct cause of death, then we would not necessarily notify that death to the coroner. Death which occurs as a result of poisoning, trauma, injuries inflicted by themselves or through actions requires notification to the coroner. So hanging, deliberate ingestion of medicinal, non-medicinal products to excess is in this group. John has previously reviewed of who can write a death certificate. If there was no attending registered medical practitioner, then the death requires notification to the coroner. And in line with the framework set out by the Coroners and Justice Act, the recent death legislation regulations of September, there is a medical examiner certificate which facilitates registration of death in so-called exceptional circumstances when there is no attending practitioner, or there is an attending practitioner, but the attending practitioner is not available within a reasonable time to write the attending practitioner death certificate. And although reasonable time is not defined within the regulations, it's generally accepted to be 5 working days, not 5 calendar days. The death is notified by the medical examiner to the senior coroner, and following coronal review, where there is no duty to investigate the death, then the medical examiner can write a medical examiner death certificate. Neglect applies if the deceased was in a dependent position, such as a person that was severely disabled as a consequence of perhaps cerebral palsy with an unsafe swallow due to neurologically driven oropharyngeal dysphagia, and there was a failure to procure them with certain basic and obvious requirements such as shelter, food, hydration, then the neglect rider is upheld. If the death occurs in custody, many of you may have had current or past experience in prisons as a police surgeon, where death occurs in otherwise state detention, including active mental health act sectioning, then that death requires notification to the coroner, even if the death is a natural event, such as a myocardial infarction and unrelated to their mental health issues. If the identity of the deceased is not known, then we don't know what their past medical history is, and by virtue, there will be no notification by their attending medical practitioner to the medical examiner service. So that death requires notification to the coroner. Going back to the reasonable time for an attending practitioner to attend, I think the accepted guidance both locally and from the Chief Coroner's Office is 5 working days, not 5 calendar days, so essentially a week, allowing annual leave to take place and for an attending practitioner to return. But I think if it's longer than a week, then that exceeds the usual turnaround time for a death certificate to be generated after a medical examiner review, registration with the registrar that would prompt a medical examiner certificate to be generated. So I hope, Dr. Latif, that is addressed. And then finally, if the death is typically considered to be unnatural and not resulted from a naturally occurring disease, run its usual course, for example, a housewife that is being cleaning her husband's overalls that contain asbestos fibres, and the housewife develops asbestos-related conditions such as mesothelioma, despite not being in a official job of occupation, then that would fall into that criteria. I'm just going to end, if I may, because I think it's very important that we have an almost free-for-all questions at the end, and to review where we are with the Nottingham City and South Nottinghamshire Medical Examiner Service. And I think it's been business as usual following the rollout, thanks to the support and help of both the senior coroner, but moreover our GP colleagues, where there's been systematic and routine medical examiner scrutiny of our community deaths since the service was rolled out in earnest in April 2023. The typical number of deaths that occur outside the hospital is in the order of 250, which exceeds slightly the number of deaths that occur in our hospitals. Are we obtaining scrutiny of both community deaths and hospital deaths? Yes, I pedantically, before the statutory death regulations in September time, access each and every death certificate and look back to see whether or not there was an accompanying medical examiner certificate. And the grey line here is the registered deaths by virtue of the death certificate at the registrar's office. The blue line corresponds to the community deaths that have undergone medical examiner scrutiny. Orange line refers to hospital deaths undergoing medical examiner scrutiny, and the sum of orange deaths, hospital deaths, blue of community deaths equates to the number of registered death certificates as a quick proxy way to say, do you believe me? Well, yes, I know what deaths are occurring in both inside our hospital and outside our hospitals. Our medical examiner service has 85 linked GP surgeries, but we know the demography, the patient population, particular GP surgeries serve, differs. For example, Cripps has a very much younger patient population with a low number of deaths, but even with our large practices in inner city Nottingham, we'll perhaps see 6 to 8 deaths each month. So although we don't receive referrals from all 85 GP surgeries each month, that is because there hasn't been a death in that particular surgery for that month. But the statutory regulation introduction in September time has not caused any change. It's business as usual. I'd just like to finish on pattern of notification. It fills us with horror of, oh goodness, is this case I'm involved with going to be notified to the coroner? I've looked at over 4,500 community deaths before the change in legislation in September of this year to then what's happened since. Before the change in legislation, there was a 1 in 4 rate of community deaths being notified to the coroner. Predominantly 1 in 2 of such deaths, the coroner issued what is called a 100A, where no further action, no further investigation, but remaining half of deaths notified involve further coronal investigation, including inquest. Since the change of death legislation in September time, the rate of coronal notification has very much fallen at a less than 1 in 5, principally because the major driver for such notification, particularly in community cases, was due to absence of an attending practitioner. We can see that there is a lot of trimming of the fat with now the loosening of the last seen within 28 days going. So it's not really all down to the medical examiner service, it's due to the statutory changes as well. But although there's a lower rate of notification of death to the coroner, it is more likely that the coroner will take such a death notified for further investigation with absence of attending practitioner skimmed off, allowing the coroners to really concentrate on what deaths we feel as medical examiners require coronal investigation. This chart demonstrates the most common mode of notification to the coroner. Blue is before the changes in September, orange of since September time. Before, the most common reason for notification was due to absence of attending doctor, and then in second place, cause of death unknown. But now we've trimmed off the last seen within 28 days rule, which no longer applies. Fortunately, why do we involve the coroner? We just simply do not know the cause of death. And that requires further coronal investigation, typically a post-mortem. With respect to turnaround time, before the legislation, there was an average 5.5 days from the death of a person, referral to the medical examiner service, writing of a death certificate and registration of that death at the registrars. Nottingham City had the slowest turnaround time in the country. Thankfully, with the new death legislation guidelines, the clock starts ticking when such a certificate lands in the registrar's hands. But still, we have this 5.5 days where it takes from the death of a person to where the certificate lands in the registrar's hands. So it's with sincere thanks for each and every GP surgery, GP colleague, our admin team and the GP surgeries for their continued support and engagement in such statutory practice. I'm going to pass back to John briefly before ending on NEMS out of hours expedited deaths. John, over to you.
Right, so just a couple of practical things. Please just refer everything to the ME service initially, even if it seems absolutely bond or obvious that it'll be going to the coroner, because the coroner is expecting us to conduct a review, and then we will handle the onward referral to the coroner for you. Other than that, nothing really very much has changed. The review that the MEs take is what we call an appropriate independent review of the medical records. We are not there sitting looking for fault. That does not mean if we find something that we think isn't brilliant that we won't draw it to your attention, but that isn't our main reason for doing these reviews. The process of coming to a cause of death is an agreement between the person who's going to write the certificate and the ME. We are not trying to impose our views upon you. And if you disagree with us, let us know and we'll talk to you. Our current contact with you guys is via email. We hope that's okay. It is very difficult getting through to medical practices on the phone, but if you are concerned about anything, please feel free to contact the bereavement office. We will answer. It's a lot quicker getting through to the bereavement office, except maybe at 10 o'clock in the morning when the phone's open to next of kin. Your call will be answered very quickly, and there's always an ME there. Next slide, please. So what actually happens after we've done the scrutiny is the MEOs will contact the next of kin. They're particularly looking for employment history. They are very good at explaining the reasoning behind causes of death. I'm convinced, I haven't got any evidence for this, I'm convinced that the action of the MEO saves complaints. Once that contact has taken place, and we always do that first, for example, if we get an employment history that would then mean that the case needed referring to the coroner, we might as well do that in the first email to you. We will contact you, we'll agree a cause of death. You then write the death certificate, you then send it to us. I think virtually everybody is doing this, but in PDF format, because it allows us to sign it, please. And then we pass it on to the registrar. It seems to be working pretty well. I have to say, we've not seen any major problems. Just the final slide, and then we'll do any questions. I don't know if you wanted to talk on this one, Nina, or I'm happy to talk on it.
Thanks, John. So as you've seen from our, maybe I went over it too quickly, of the turnaround time, we usually turn around such a receipt of what you're considered referral within a day. Within a working day. That is our standard practice, and we operate a 7-day service. With respect to certain deaths, so-called expedited deaths, where that person has a religious belief that would help support, facilitate an early burial, such as those persons of Jewish belief or of Muslim belief. Our GP surgeries during working hours are very helpful to give a heads up email, in addition to the standard referral mode of, I sent through a referral, pleased to let you know this is an urgent expedited death, and we will bump, understandably, that person's medical examiner scrutiny to our attention to try and oversee such a burial to take place before the sun goes down. I'd just like to end on the constant headache, and that's why I blame myself for being very grey, of each Monday morning I will typically get a lot of feedback from EMAS, NEMS, the coroner, regarding out of hours deaths. So I'm very grateful to the exceptional and very challenging duty our out of hours GP providers deliver tirelessly. And I think If you are invited to assist with death administration, I would just try and just take a step back. If the death is expected, then our registered nurses will undertake such death verification. Regarding reporting of that death, have the family shared that this is a person of religious belief that would lend itself to an expedited burial. If that is not the case, which is in likely 95% of cases, simply, I don't mean to underplay the importance of such verification of death, but our NEMS team are there to diagnose death, provide verification, and then move on to their next duty. The next working day, that person's GP surgery will then routinely notify their medical examiner service of that person's death. So there's no requirement for NEMS to notify the medical examiner service of an expected death that is not requiring an expedited, facilitated death administration. The only time where NEMS require to notify the medical examiner service is when an expedited death administration is invited. In the case of a person of Muslim religious belief, a Jewish religious belief. However, invariably, such a NEMS colleague has not seen the person in life. If you haven't seen the person in life, you cannot write the death certificate. So please don't write the death certificate, because you can't write that you've seen this person in life. You've only seen them after death. However, to help facilitate the administration, and again, I'm sorry to talk about the bureaucracy and paperwork involved in their death administration, there is a very simplified referral form from NEMS to send to the medical examiner service, and it's contained in this managing out of hours expedited deaths at the weekend. It's simply, again, famous last words, involves NEMS colleagues saying this death has been verified, this person is of religious belief that would require an expedited death. Here's the name of the patient and their usual GP surgery. They submit such a form by their NEMS email to the ME service email address, and then they go on to their next duty. There is no requirement to all go through the switchboard, let's phone the on-call medical examiner, or let's phone Miss Casey, the senior coroner at bed at night. No. Death is being verified. You've established that death would lend itself to an expedited release and burial. Let us know, the medical examiner service, of that. It could be 11 o'clock at night. It could be 3 o'clock in the morning. Just tell us of that patient's name, and the next working day at 8 o'clock, such an email will be then answered and acted on. It is pointless. There is no need to contact the coroner nor the on-call medical examiner, because at 3 o'clock in the morning, the registrar will not be there to oversee registration of such death certificate. The registrar is open purposely between 10 AM and midday on a Saturday and Sunday to be able to register such death certificates. So between 8 and 10 is the window that the duty medical examiner on a Saturday and Sunday will receive such NEMS emails of heads up, never met this patient, but they are of Muslim belief, they're an expedited death, here are their details. Then go on to your next duty. You don't need to follow up, you don't need to check that your email is being read, it will be read. And I will double check with Jasnita, the medical director of NEMS, that the current community partner guidelines are on the NEMS server, as well as I'm pretty sure this expedited guidance is also on the NEMS server. So I think if I may now open any questions, if anyone would like to put up their hand, John and I will do our best to help address these questions.
Thank you, Nina and John. I think we do have one question that I think might not have been addressed about would homicides would need to be referred to ME as well, because it seems to be different in other areas of the country.
Okay, so all deaths reported to the coroner require a prior medical examiner scrutiny. The GP surgery, once they hear of a diagnosis of death received, to refer that person's death to the medical examiner service as per normal practice. However, you use the word homicide. Homicide is a unexpected suspicious death, which means the police will be there leading the diagnosis of death and directly liaising with the coroner. The coronal notification has been done by the police, but the past medical history and events, circumstances surrounding the death, what the person's past medical history is again contributory to such an assessment by the coroner. So every death, whether it's expected, unexpected, requires a prior medical examiner scrutiny. So please descend as you are. Every death of a patient in your practice, the medical examiner service.
So we've got everything. We've got a handout that we will be sending through. Is there out of hours expedited death guidance included in that?
I will forward that as a separate document to you, Saira, if I may, yes, but I'm pretty sure it is on the NEMS guidance palette. If it isn't, I will come to NEMS and happily do a teach and refreshing session like I've done with the NEMS team leaders.
I think we have got another doctor, Nina, who did say that she's seen the guidance in the NEMS hub folder, so I think it exists. So hopefully you can. So I think we've got a hand raised from, is it Dr. Latif? Is that still correct?
Hi there. I think it was a legacy hand, but it's fine. Thank you so much. I really appreciate this really thorough, quick whiz through tour of the guidance. I was in a meeting with the chief coroner in Leicester just about 6-7 weeks ago, and there were some differences of advice that he gave that we are working slightly differently locally, which is absolutely fine as long as we are all working on the same page. For example, he clearly mentioned that the 5-day rule of what is expected as a reasonable delay is not a standard thing. So he's categorically mentioned that in that particular meeting. And Leicester tends to follow a slightly different rule, but it's good that, at least we have got some idea of what a reasonable delay is. And thank you so much for raising this issue of course, expedited, kind of request for MCCD, not just for religious reasons, but of course there are some other reasons as well, where religion isn't the main reason for requesting MCCD. Just one quick question, and it's probably because I haven't seen the form or the pathway for the request over the weekend. So I believe, and I'm on the of the understanding that the office is not open on the weekend, but our colleagues who are on call will be checking the emails. How can we make sure that that our colleague has received it, and if there was any follow-up to be made, because of course we don't want to be ringing colleagues unnecessarily, but equally want to be sure, because those of us who have got a large population of Muslims or Jewish patients, we do see, although not a lot, but we do see occasionally these things happening, and families really concerned. So some guidance or advice regarding that would be really helpful. Thank you.
Thanks, Dr. Latif. Again, I'm sorry I'm hammering NEMS and out of hours guidance, but and I don't mean to downplay, my very simplistic, rule of thumb. If it's for an expedited death, thank you for letting us know. That is, your role as the NEMS out of hours provider. This should be documented in the primary care notes, so it's visible, and there is your handover of one of the NEMS district nurses has undertaken a verification of death. The family have shared that they are of Jewish religious belief and request an expedited burial. You're required as the NEMS clinician to complete a very basic referral form by email to the generic medical examiner address, which will be read, which will be actioned from 8 o'clock the next working day. As your handover to your colleagues, you can write in your NEMS clinical notes, which is uploaded, as you know, to the primary care notes of, I have let the medical examiner service know, I've informed them of this death, and then that's it. You don't need to check that we've read it. You don't need to check that the email has gone through. It's there in the primary care records. Of course, we're all like, oh goodness, I don't want to get this wrong. I don't want to cause unnecessary distress to the family. But the system and process works. We typically have 5 to 6 expedited deaths each week, of which 1, 2 typically happens at the weekend. So this process and system does work, and I think key is educating the NEMS team leaders, the so-called sisters in charge, who are there directing sometimes locum colleagues who are not used to local processes of what to do. But let us know by email, hand over by writing in the primary care notes, and move on to your next duty. You're busy enough on your NEM shifts to be double checking.
Thank you very much. I think that's the time up, I'm afraid. But if there are any urgent questions, I mean, I think Nina's kindly shared her email as well if you've got any questions. But also please do fill in our survey form, and if you've got any other concerns or questions, any other topics you'd like to see, then please do let us know as well. Thank you very much for coming and sparing your time this evening.